नमस्कार, आदाब, हेलो एवरीवन। मैं कीर्तिदा ओझा आप सबका हार्दिक स्वागत करती हूँ। Extending a warm welcome to all our viewers who have logged in from various locations in India and across the borders. This is Sjogren's India's first online live talk with guest expert Dr. Sapan Pandya. September is Rheumatic Diseases Awareness Month. So today's talk will focus on rheumatic diseases, challenges and hope. हम आज गठिया रोग के बारे में बात करेंगे। गठिया रोग में जो चुनौतियां और उम्मीद है उनके बारे में हम बात करेंगे। We are trying out a bilingual format to cater to the needs of the audience. हम दो भाषाओं का प्रयोग करने की कोशिश करेंगे, इंग्लिश और हिंदी। कार्यक्रम की रूपरेखा देने से पहले मैं आपको शोग्रेन्स इंडिया के बारे में एक झलक दिखाना चाहती हूँ। अगली स्लाइड में आप देखेंगे शोग्रेन्स इंडिया की कुछ झलकें। Sjogren's India is an informal group initiated and managed by patients in order to support other patients to live well with their disease. Patients द्वारा patients को support देने का ये एक प्रयत्न है। Although our primary focus is Sjogren syndrome, we have members suffering from other connective tissue diseases also associated with us. Sjogren's India supports patients and families through education and informal counseling support. We have developed educational material in local Indian languages. Public awareness programs have been done using print, broadcast, and social media. We have forged strong linkages with doctors and patient support organizations across the world. Today, I would like to especially thank all the support groups who have helped us reach to a wider patient pool. Now, let me take you through the program outline for today. Can we have the slide, please? जैसे कि आप देख रहे हैं, वेलकम और इंट्रोडक्शन के बाद मैं आपका परिचय कराऊंगी गेस्ट एक्सपर्ट डॉक्टर सपन पंड्या जी से। उनका टॉक होगा रूमेटिक डिजीजेस, चैलेंजेस एंड होप। टॉक के बाद हम ऑडियंस में से क्वेश्चंस लेंगे। उनके प्रेजेंटेशन के बाद जो प्रश्न आएंगे वो प्रश्न आप हमें व्हाट्सएप टेक्स्ट मैसेज द्वारा भेजिए। अभी अगली स्लाइड में आपको नंबर दिया जाएगा। कृपया आप अपना नाम और लोकेशन भी भेज दीजिए। ध्यान रहे कि व्यक्तिगत प्रश्न हम नहीं ले पाएंगे। We will not be able to take questions which need medical consultation. Once the program, the questions are over, we will love to have your feedback and comments. You can leave your feedback on the link that we have provided, which will be, so you can put your feedback on the website itself, or you can send us your comments and suggestions for new ideas or topics to be taken in the next programs by WhatsApp. We will end the program with some take-home messages. So take a look at the number on your screen. Please note it down. इस नंबर पे आप अपना टेक्स्ट मैसेज भेज के हमें प्रश्न पूछ सकते हैं। अब मैं इनवाइट करती हूँ डॉक्टर पंड्या जी को कि हमारे साथ आए और ये प्रोग्राम को आगे बढ़ाए। वेलकम डॉक्टर पंड्या।
थैंक यू।
very glad to have you here with us. Dr. Pandya is an eminent rheumatologist of India. He has been practicing in Ahmedabad as a consultant rheumatologist in the Vedant Institute of Medical Sciences since 2003. He also works as an honorary rheumatologist at the VS General Hospital, where he can provide his services to the poorer sections of society. Dr. Pandya is an accomplished research writer. He contributes to journals, and he is currently the editor of the Indian Rheumatology Association's e-bulletin. He has also been a very active member of the Indian Rheumatology Association and organized the annual conference of IRA in 2012. We are very happy to have Dr. Pandya here, who is not only keen on his looking after his patients, but also supporting activities such as ours. He has been one of our strongest supporters right from inception. इसके अलावा उन्होंने और भी एक एंकाइलोसिंग स्पॉन्डिलोसिस के लिए सपोर्ट ग्रुप को सहायता दी है. He is involved in taking the field of rheumatology ahead by encouraging younger students to join this program. He has been instrumental in setting up a program which has been approved by the Gujarat University, and this will help in students taking a formal course in rheumatology. I would like him to take over now and tell us more about rheumatic diseases, challenges, and hope.
Thank you. Thank you, Kithavan. There are a couple of things I want to say before I start my formal presentation. The first is that I must thank both Sjogren's India, the support group, and CyberSurf, the company which is helping us with this, with the linking all of us together. And this is one of the first webinars that I'm doing which is without any kind of industry support, which means any kind of pharmacological industry support. And that I think is a great thing in itself. Number one, Kirtida Oza is, I don't know if she introduced herself, but is the president of the Sjogren support group. She herself suffers from Sjogren syndrome, which is connective tissue disease, but has been working on this for the last almost 10-15 years. So I think we must congratulate her for taking these things forward. And the third thing is that I'll be doing my presentation mostly in English because I gather there are people from even international areas. And a couple of things I'll speak in Hindi also for our local crowd who cannot follow English altogether. So with that, I will not be discussing rheumatoid arthritis in my connective tissue diseases because rheumatoid arthritis itself is a presentation in itself. It will take a long time. So with that, I think, but I'll be happy to answer any questions that you have at the end of my talk. So I think we'll begin with the presentation. If I can have the first slide, please. Yeah. So if you can have the first slide. This is going to be the outline of my talk. I'll first give you an overview of the connective tissue diseases, and then we'll come to the specifics of these diseases with some photographs, real-life photographs. I'll be discussing about challenges which the doctors face and the patients face. Then I'll be talking about the principles of treatment, broad principles, because normal treatment is individualized in a patient, but I'll be talking broadly on the principles and few myths and pearls regarding the principles of treatment, about research and what the future has, and then the last slide on the take-home message from this presentation. ये हमारा आउटलाइन रहेगा प्रोग्राम का, जिसमें हम बीमारियों के बारे में चर्चा करेंगे और उसके बाद कौन सी ट्रीटमेंट देते हैं, किस तरह इनको मैनेज करते हैं, और लास्ट में एक स्लाइड रहेगी जो आपको बताएगी कि इस प्रोग्राम में से आपको क्या मैसेज लेना है. So rheumatology, the word rheumatology, rheumatism in Latin means fluid, and rheumatology is the study of rheumatism. Rheumatism word is very non-specifically used generally for any kind of aches and pains which happen in the body. And the specialists who deal with these kind of pains are called rheumatologists. Now, broadly, we have three categories of diseases. One is arthritis, which deal with various kinds of arthritis that patients have, which is joint involvement. Then we have the connective tissue diseases, which I'll be coming to that shortly. But these involve the joints and other organs as well, like the lungs or sometimes the heart or the brain. And then there are vasculitis, which are basically, again, autoimmune diseases which affect the blood vessels of our body. These are all most of these diseases are autoimmune diseases, the disease that we deal with, which means that your own immune system acts against your own body. That is also called, which was historically called horror octotoxicus, which means that your own body starts acting against, your own immune system starts acting against your own body. Now, how are the immune system and the joints connected? It's because the the joints, the synovial lining of the joints is rich in immune cells. And therefore, this is a target organ. There are also other areas like the basement membrane of the lung or the basement membrane of the glomerulus, which is in the kidneys, which are involved. So, जहाँ पे भी body में immune cells rich हैं, वहाँ पे ये बीमारियाँ affect कर सकती हैं. So the other organs which are likely to be affected are the eye in some diseases, the lungs, the kidneys, sometimes the brain, but almost always the joints and the skin. Why are they important? It's because now the diseases that we deal with constitute only about 1 to 2% of overall prevalence in the population. So something like diabetes or tuberculosis is much more common in our country. But then these are important because with increasing lifespan, these diseases are becoming important. They cause a lot of morbidity, and some of them also cause mortality. So to an individual patient, they become important to diagnose and treat. Now, if you understand what is the logical treatment, if you understand the mechanism of the disease, since it is caused by the immune system, and your immune system is in a way increased, so you need to actually decrease the immune system, which means you need to give immunosuppressants. Now, this is one myth amongst patients who say that हमारी immunity कम है. Actually, इसमें immunity एक तरह से ज़्यादा होती है. It's more. So you need to suppress it by giving immunosuppressants. I'll be coming to a bit of that again during the treatment part. So what are the common features? First, let me tell the common features of all these diseases, and then we'll come to the specifics. The age is generally they're young and the middle age, mostly females. There are theories why females are affected more than males. Pregnancy bearing age group, again, depends on which disease you're dealing with. But from there on to menopausal age, you can have more commonly presentations. The symptoms are generally constitutional features, which means fever, weight loss, anemia, those kind of things. And you have almost always have musculoskeletal involvement, like joints in the form of arthralgias or arthritis. You can have muscle involvement in the form of myalgias, which means muscle pains. You can get various kind of rashes in some of these diseases. I'll show you pictures of some of them. You can get mucous membrane involvement in the form of oral ulcers, sometimes genital ulcers as well. And then there is also a phenomena called Raynaud's phenomena, which is basically the fingertips turn white or blue when in cold. उंगलियां सफेद या नीली पड़ जाती हैं जाड़े में. That's called Raynaud's phenomena. And then you can have cardiopulmonary involvement because the lungs and the heart can get involved. The kidneys, the brain, the peripheral nerves, sometimes the gastrointestinal tract, and the eye. Remember is that the organs like the kidneys, brain, nerves, and gastrointestinal tract and eye are not very commonly involved in the sense that depending on diseases, individual diseases would be involved in roughly from 20 to 40% of cases. Many of the cases just have minor symptoms like skin involvement or musculoskeletal involvement from a joint pains, which are not really life-threatening. The key, by differentials, we mean what are the other diagnoses that can mimic these diagnoses. In a country like India are obviously infections. Something like tuberculosis, which can also affect all these organs, is something which is always in our mind. Leprosy, again, is one disease which not uncommonly mimics these diseases. So, and the other differential is malignancy, sometimes cancers, especially when your age is above 60 or 70, they can have these kind of manifestations. So these are the other diagnoses that we always keep in mind before we confirm the patients having these diseases. So now what is the etiopathogenesis, which means what is the mechanism, how do these disease, kai baar questions patients पूछते हैं कि साहब मुझे ही क्यों हुआ ये. Now that's a difficult question to answer, but there is an interplay of genetic and environmental factors, which means now the moment you say genetics, most patients will jump to कि मेरी family में किसी को नहीं है, nobody in my family suffers from this disease. But by genetics we mean that you have those kind of genes which make you vulnerable to certain diseases, but just the presence of genes doesn't confirm that you will get the disease. So there are obviously environmental triggers. For example, it's now clear that rheumatoid arthritis can result more commonly in smokers. So smoking is a risk factor for rheumatoid arthritis. Similarly, the gums, the lining of the gums of the teeth, they can be a risk factor for rheumatoid arthritis as well. So different diseases have different environmental triggers, and there are genes. So the right combination of genes and environmental triggers which gives you autoimmunity. Now, autoimmunity doesn't mean autoimmune disease. So some of these patients just have the blood reports which carry the autoimmune problem, but they still don't get the disease. So few of them will result in disease. So this is a combination of genetics and environmental triggers. Now, the course of illness generally in these patients, since it is your own immune system which affects your body, most of these patients would have the disease for a long time. Again, mostly lifelong. So but the course of the illness, depending on individual disease, generally slows down with increasing duration. So most of the disease, whether they're talking about lupus or whether they're talking about scleroderma, the main organs and lungs would be involved in the first, or the kidneys in the case of lupus, would be involved in the first 3 to 4 years. एक बार आपके 3 या 4 साल निकल जाए, involved होना is uncommon. ऐसा नहीं है कि नहीं होता है, but it's not very common. So the other thing to understand for us, especially doctors, and also for patients to know, is कि लोहा जब गर्म हो तभी उसको मारना पड़ता है. So there is a window of opportunity when there is swelling. That is the time you treat these patients, because if you have, अगर time निकल गया है, so then there is no point in treating something. For example, rheumatoid arthritis, जब deformities हो जाती है, when you already deformed, there is no point in being very aggressive in treating these patients. So you have only about 6 months to 1 year period where you can really make a difference to these patients. Again, depending on individual disease and organs involved. If you don't treat this, some patients ask me, sir, हम treatment नहीं लेंगे तो क्या होगा? Well, you can result in complications like renal failure in the case of lupus, or in scleroderma. There is also mortality. So some of these patients die because of the lung disease or the heart involvement, and that's why it's necessary to treat these patients. I tell my patients that treatment is not an option. Going to another doctor is an option you have, but you need to take treatment. Now, there are special issues concerning children and pregnancy, which I will probably deal with individual diseases, or we can take it up during the questions. Now, that's a photograph. The first photograph is taken to the left upper corner, is taken from our textbook, which shows Raynaud's very clearly. You can see the whitish discoloration which happens in cold. Very clear in international patients, Caucasians. In the dark-skinned people, it's a little difficult to see, but it does happen. On the left lower corner is what we call pitted scars. That's because of lack of blood supply to the fingertips. Again, seen in disease like scleroderma. On the top right corner is what we call sclerodactyly. If you can see the fingers, the skin has become taut. It's become thick. You cannot pinch these people. And very interestingly, one of my patients called up from the faraway village saying that I cannot pinch my wife's skin. And I said, that's a great way to say that this is actually scleroderma. And on the right lower side, you can see what we call telangiectasia, which means these are blood vessels, capillaries, which are dilated. And that's normally a long-term complication of scleroderma. So, and that's lung involvement in scleroderma. This is a CT scan showing that lungs can be involved in about 40 to 50% of these patients. Sometimes it can be really bad. So that is scleroderma, where you get white. It starts with bright, fluid, bluish discoloration of the fingertips. They go on to have tight skin, and then there are non-healing ulcers of the fingertip, which I showed. You can have joint pains in these patients, arthritis, and when they get lung involvement, they start coughing, they feel breathless. In about 15% of cases, in a particular subset of scleroderma, you can get heart involvement, which presents with chakkar aana, giddiness, sometimes chest pain, and those kind of things. And you can have rarely kidney involvement in just about 1% of cases, where you get high blood pressures and the creatinine, which is blood reports, starts rising. Now, there are blood reports which help you diagnose scleroderma, but most of these diagnoses are clinical, which means कि मरीज को देख के उनके symptoms पे से diagnosis की जाती है. The blood reports just help you. There is a test called ANA, which is positive in most of these patients. It has to be done in the right way. And then the hemoglobin can be lesser, the ESR can be raised, which suggests that the disease is active. And the simple urine report can tell you if there is a kidney involvement in these patients. The course of the illness of scleroderma, well, generally depends on whether it's limited or diffuse. There are two variants of scleroderma. But in the initial 3 to 4 years, the skin tightening increases. In diffuse, it involves the whole body. In limited, it's just areas of hands and forearm, and then the hands and the forearms and the leg which are involved. Over a period of 10 to 15 years, gradually the skin starts becoming loose on its own, but it really never comes down to the normal level. Now, it's during the first 3 to 4 years when the skin is tightening that the lungs also get involved, and really the kidneys can get involved. So that is the time to treat these patients, if at all. Now, coming to the second disease, if you can see on the left upper side is what we call alopecia. There's a lot of hair fall there. And on the right lower corner is what we call palatal ulcers. These are very specific for lupus. That's systemic lupus erythematosus. The name lupus means, again, wolf in Latin. And the reason it's called wolf is because the rash, the butterfly rash, is like the whiskers you see in wolves. That's how the name came. And they have rashes all over the body of various kinds. They can have, again, joint pains. You saw the palatal ulcers. They can have oral ulcers, which are essentially painless. And then about 50% of them have kidney involvement. So that comes with swelling over the legs and the feet, sometimes breathlessness. They can have lungs involvement rarely, and there is a form called diffuse alveolar hemorrhage where they can also cough out blood, which can be serious sometimes. You can get pneumonias in lupus. The heart is involved in a few cases. The brain, very importantly, the central nervous system can be involved, and depending, more common in childhood, and they can present with seizures, and there are various manifestations of the brain in lupus. The nerves can get involved. It can result in neuropathy, where you have tingling and numbness in your hands and your feet. The blood reports, the ANA is the most important test in lupus, and you only have about 1% of cases which are ANA negative. Most cases would be ANA positive. And then there are other reports like the DSD and complements which help us decide if these patients will get kidney involvement. The course of illness of lupus can be a fulminant illness, especially with younger age. But generally, almost 70 to 80% patients do well in the long run. They need treatment. There can be treatment-related complications. But the lifespan of most of these patients is now much better than before. We lose about 20 to 30% of these patients in the long run. But it can be a waxing and waning course, and you need to alter the therapy accordingly. That's the third illness that I'm coming to. I know I'm going a little fast, but I'll take up your questions if you have any in the question answer session, because I have only about 5 or 6 minutes to complete my presentation. And this is a rash. If you see in the knuckles and the hands, this is a rash called Godwin's papules, and that's diagnostic of a disease called dermatomyositis. So inflammatory myositis, just as in rheumatoid arthritis, you get joint involvement because of the disease. In myositis, you get muscle involvement because of the disease. The muscles get inflamed, mostly the proximal muscles of the arms and the thighs, which means you have difficulty getting up from sitting position, and these patients cannot comb their own hair. Now, the manifestation can be mild to very severe. Some of these patients are bedbound. They can get neck muscle involvement. They have swallowing difficulty because of the pharyngeal muscle involvement, and that is a red alert for us, because patients who get pharyngeal involvement and neck muscle involvement can get problems of respiratory failure, and they cannot breathe because the chest wall doesn't expand, because the chest muscles also get affected. So if the neck muscle and swallowing difficulty is there, we normally sometimes have to admit these patients in ICU and give them intravenous urgent treatment. They can have various forms of rashes, especially dermatomyositis. I showed you one of them. There can be other rashes on the trunk, on the necklace area, and elsewhere. About 30% of them get lung involvement, sometimes very severe. Intriguingly, in patients who don't have that much of muscle weakness, there can be lung involvement more commonly. That goes with skin involvement. The heart is involved because of myocarditis in some of these patients. They have difficulty breathing. The blood reports in these patients, we normally ask them to do muscle enzymes like the CPK, the LDH, and the AST, ALT, mostly the AST, which are raised in these patients. And they also have to undergo sometimes electromyography EMG report. And then there are the ANAs again. There are muscle-specific antibodies called the MSAs, which are now done. There are some costly tests, but help you these patients. The course of illness, I mean, it's a very varied manifestations of these. So depending on what kind of illness you have, whether it's dermatomyositis or polymyositis, you can get mild or severe disease. If the pharyngeal muscle is involved, there is difficulty swallowing, and the chest wall muscles are involved. These patients have a grave future, and one has to be very careful. Otherwise, you can lose these patients. They can also die because of lack of ability to breathe. But otherwise, those with lung involvement can sometimes be very severe, and we have seen cases, and we have read cases where, despite all kinds of treatment, the lung doesn't respond. But otherwise, generally, they carry if you diagnose early again and treat them well, early enough and properly, then most of them do well in the long run. So that's as regards dermatomyositis and polymyositis. Now, this is the fourth disease that I'm going to discuss. You can see the rashes on the legs. Characteristically, these patients complain that these rashes increase when they are in a standing position or a sitting position, when they dangle their legs, and they become lesser when they become horizontal. So that's called Waldenstrom's purpura, and it's because of globulins in the blood, proteins which are raised in the blood, and this is one of the features of what we call Sjogren syndrome. Generally, Sjogren syndrome patients have dry mouth and dry eyes. That's a necessary criteria for the diagnosis. Almost 80% of patients or 70% of patients just have what we call sicca. Sicca means dry mouth and dry eyes. You can have sicca in the eye or sicca in the mouth. 20-30% of patients have the kind of rashes that I've showed you. These patients also sometimes have parotid involvement, which means recurrent parotitis. Now remember, mumps is a disease of childhood. You've had mumps once, you are lifelong immune. So if you get mumps recurrent in an adult, you have to suspect this as one of the diseases you can have. You can also get lymph node involvement in the cervical area, especially sometimes in the submandibular gland. You can get the purpura that I showed. There can also be a vasculitic purpura, which is again this kind of rash in the legs and the forearms and elsewhere. Some of these patients, about 10 to 15%, present with paralysis, and doctors find very low potassium in their blood. Now, so whenever you find cases of paralysis who have low potassium in the blood, especially women. Now again, all these diseases I've discussed are more common in women. Sjogren's is almost 9:1 ratio in female to male. So a woman who has a low potassium and has a recurrent low potassium paralysis, one has to get an ENA done and rule out Sjogren's syndrome in these patients. It's because of kidney involvement in these patients. You can have brain involvement, you could have spinal cord involvement, rarely in these patients. You can get optic neuritis, which means you lose vision in the eye sometimes. The blood reports, this is a disease where the anti-Rho antibody and the anti-La antibody is very useful. The ANAs are positive in these patients, and the anti-Rho and the La is positive. Some of these patients, especially the ones which I showed with purpura, have raised globulins in the blood, very high globulins, and you can have active sediments in the urine if you have kidney involvement. The patients who have purpura generally have a very high ESR. The course of the illness, except for the 20-30% who have this high globulins in the blood and the kind of purpura I showed, or kidney involvement in the form of low potassium, the rest of the 70-80% generally do very well with basic treatment of the dryness. The 20-30% that have these kind of presentations are the ones who are more likely to go into what is called lymphoma, which is a kind of blood cancer, but it's an indolent cancer, so it goes on for years together. The lifespan of Sjogren syndrome patients the world over is now believed to be equal to normal population. So it's being treated very well the world over, and so there's nothing to worry there. Now, there are also, to confuse the matters further, there are also overlap syndromes, which means you have 2 or 3 diseases which are the features of 2 or 3 diseases. For example, there's a disease called mixed connective tissue disease, where you get Raynaud's phenomena and puffy fingers, and you can get manifestations of rheumatoid arthritis, inflammatory myositis, those kind of things. There is also a disease we call undifferentiated connective tissue, which means that you have 1 or 2 features with a strong ANA positivity, but these patients have yet not evolved into any one disease. Lupus is rheumatoid arthritis with lupus. These patients have rheumatoid with lupus. Polymyositis, scleroderma overlap, which means you can get scleroderma and myositis. There are cases of Sjogren's and lupus overlap. And then these are the other, you can read on the slides, are the other kind of overlaps that you can rarely get. But basically, the common features are the ones that I said. and you treat them with the same principles. Now, what are the challenges? So the challenges with the doctors, for us, the first thing is to be aware of these diseases. So the doctors have to be sufficiently trained to be aware of having seen these diseases, being able to diagnose them early, referring them to a specialist, basically a rheumatologist early. Because as I said, there's a window period that you can treat, and once the window period is gone, it becomes very difficult to treat these patients. For us, it's important to differentiate whether the patient's disease is active or whether it is damaged. The way I said that if there are already deformities, for example, in rheumatoid, then there's no point in being very aggressive. So similarly, in all these diseases, there is a phase called the burnt out phase, where the damage is done. Basically, Hindi mein kehte hain, chediya chuk gayi khet. So then you don't be very aggressive in treatment. Giving time to patients is very difficult in a country like India, where there is a huge population of patients. So many of our patients are not satisfied because of the time that there are very few specialists. The rheumatologist-patient ratio is extremely poor in a country like India, and so to give time to these patients, educate them becomes increasingly difficult. But we are working on it to try to develop physician assistants who can deal with these patients. Less investigations and affordable treatment, something which is again difficult in our country because of economic constraints, that you have to order less investigations as less as possible and treat them with options which they can treat. For patients, the problems are reporting symptoms, the relevant symptoms early, because what happens is that when you listen to such presentations or read such stuff, most of you start thinking that even I have this illness. So it's very important to report the relevant symptoms to the doctors and go to the family doctor first, who isn't going to see and refer you to the specialist. Going to the right doctor is important. Compliance with tests and treatments. You have to find the right doctor and have a scientific temperament and try to follow the advice which is given to you. Sometimes with the access to internet, there is this enthusiasm for reading stuff. Going to the right kind of websites, because you'll find all kinds of suggestions on the internet, screening through them, understanding about the disease, and accordingly adjust expectations. Very important. The important thing to understand is that most of these diseases are not curable. They are very well controllable. And so there's no point in changing any form of therapy or doctor in expectation of a cure. Socioeconomic issues are obviously there, cultural influences, especially in a country like ours where there are stigmas, and it's not easy to understand these patients because they don't have apparent disease. For example, in rheumatoid arthritis, they can get deformities and one can see them. But disease like Sjogren's or Lupus, you cannot see Lupus, you cannot see Sjogren's. So it's difficult sometimes to understand these patients. There are economic problems also. So coming to the treatment part, the guidelines that we follow in India are, we have guidelines, our own guidelines, Indian guidelines for treatment of rheumatoid arthritis and ankylosing spondylitis, two of them. The Indian Rheumatology Association has been doing has been making these guidelines periodically every 5 years or so. But we are yet to come up with guidelines for connective tissue diseases. It is in the plan of the Indian Rheumatology Association. Most of us would follow the American guidelines of therapy. Some of them also follow the European guidelines of therapy. And so we are very well aware of these guidelines, and there is no dearth of clinical cases in our country. So we have seen enough cases to be able to treat them as well as the international experts. Coming to the treatment part, the palliative treatment is important because, for example, in Zika, you treat the dryness, the eyes and the mouth. Most of us would divide these diseases into what kind of manifestations they have. Do they have red alert signs like lung involvement, kidney involvement, or heart involvement? Then you obviously treat them with immunosuppressants like steroids or other immunosuppressants. But if there's only minor organ involvement like a rash or a joint pain, then you try to manage them with painkillers, paracetamol, local steroid injections, and those kind of things. But if it's an organ-threatening problem like the eye, then you have to be aggressive, sometimes admit them and give them intravenous steroids as well. Hydroxychloroquine is one drug which is very useful in lupus. It is known to prevent further lung involvement. So we would prescribe hydroxychloroquine almost every patient with lupus. Patient with hydroxychloroquine, that is reversible. Corticosteroids, there is a lot of myth about steroids, and there are patients who would refuse to take steroids. Well, steroids is one thing that has definitely improved the lifespan of these patients, survival in these patients. And sometimes in life-threatening conditions, they are the only ones which can save your life. So used in the correct measure and by the correct doctor, I think these are very useful drugs. But it's important to come down to the minimum dose once the problem is rectified and continue the maintenance dose till you need to take them. There are other immunosuppressives like methotrexate, azathioprine, mycophenolate, mofetil, etc., which some of our patients who are listening might be on. and they are basically used to cut down the dose of the steroids. There are also some biologic which has come. The cost of these are approximately about ranging from 60,000, 80,000 rupees to about 3 to 4 lakhs per year. These are some very potent compounds, and they are normally be reserved in our country for use in patients who don't respond to the first time treatment. So what's the research? What's the future? Well, ultrasound is coming in a big way in most of these diseases, whether it is parotid measurement in Sjogren syndrome, the skin involvement in scleroderma also is being being measured by ultrasound. The joint involvement definitely in rheumatoid arthritis. So because MRI is a costly affair, so ultrasound is useful, especially in our country. There are newer tests which could be more specific. There are ELISA tests which are coming up, which will tell us more specific if the patient has a disease. Small molecules are believed to be the future. In rheumatoid arthritis, drugs like Inflammatory have already been approved, and these are oral compounds you can take easily, and their efficacy is similar to the biologics. Bone marrow transplants, autologous have been tried since the last 10 to 15 years. There is data on these now, again reserved for patients who don't respond to treatments. But if you can, theoretically and conceptually, if you can do an allogenic transplant, which means a transplant from your sibling or somebody else, then you can actually cure the disease. The problem with allogenic transplant is that there is a TRM, transplant-related mortality. So there is a mortality to the transplant itself, and we've not been still able to cut that down to less than 1%. There is hope that these diseases could be cured as well. There's a lot of work on microbiome these days, and some of you might have read these studies where they are trying to look at what the gut microbiome of these patients is, what is the normal flora of the gut in these patients. And depending on that, these patients have cytokine signatures, which means now cytokine is the predominant chemical in the blood, which is actually causing a problem in these patients. So for example, Sjogren's patients could be interferon signature patients, or they could be low interferon signature patients. The ones which have high interferon in their blood could be treated with anti-interferon antibody, and those with low interferon could be treated with other compounds. So the future will see tailor-made therapy according to the patient's chemical structure. So the last slide, I think my take-home message for all of you will be that, especially most of this will be relevant to the Indian context, would be that report early to your family doctor, report relevant symptoms, let the family doctor decide whether he wants to refer you, he or she wants to refer you to the specialist. Uncommon diseases, very important to know, these are not common diseases. Tuberculosis, malaria, diabetes, hypertension are much bigger problems. These are uncommon diseases, but it's time that we started taking care of them. They are immune mediated, and hence, since your immune system is going to be with your body for a long time, they are of long duration, mostly lifelong in most cases. And the treatment, as you would understand, is also long-term in these patients, and you need to give them immunosuppressants in some of them. Now, food has no relation in most of these. It's a very common question asked by all our patients. And there is no real evidence to show the connection of food with most of these diseases, except for the fact that if you want to keep your metabolic profile okay, then you take low-calorie compounds. You have to accept the side effects of the treatment. Steroids, as you know, are very important. You can get side effects. And have a scientific temperament, very important in a country like ours. Therapy is available as well. But I think it's very important to have a scientific temperament in terms of following what the advice is given, getting the test done, periodically visiting the specialist so that you have a good quality of life. The patient's perspective is increasingly becoming important the world over, and even in the diagnosis criteria or in the treatment criteria, the treatment algorithms, people are taking patients in their meetings before they start the treatment part. Support groups are very important, and I must congratulate Mrs. Kinta Oza and their group for doing this. I think support groups are very important, not only from the psychological point of view of supporting each other, but also they could fund research in countries like USA and UK, I'm sure, and the West. They are so powerful that they actually fund research, something that we need to start doing in our country. So I think with that, I'll end my talk. Thank you very much for the patient hearing, and I'll be ready for any questions that you would have. Thank you.
Thank you, Dr. Pandya, for telling us so much in this short span of time. Can we have the questions now? Over a cup of tea. Maybe we can just sip a cup. One of the questions that comes up very often is the risks associated with pregnancy in patients with rheumatic disease?
Coming to connective disease, I think it's important to know the risk to the mother or the risk to the child. So in a disease like lupus, there would be risk to the mother. So patients of lupus, just more than that, would flare during lupus. So for a lupus patient, the disease has to be inactive when they contemplate pregnancy. The other diseases like Scleroderma and Sjogren's, they are at an age group where pregnancy is not commonly seen, but they can again flare during pregnancy. So it's important to correct the disease before they contemplate pregnancy. And to the child, well, because of the anti-Ro antibody which can pass on to the fetus, there is about a 2% chance in the first child to get a heart block. If you have had a child with a heart block, then there is the chance increase to about 15% of the second child getting heart block. You can get a condition called neonatal fetus, where you get anti-Ro, because the anti-Ro antibody get a rash on the child, on the newborn child, but that goes away on its own. So I would say that yes, it can be a risk, but if the disease has been quiescent, you can contemplate pregnancy under the supervision of the rheumatologist.
Thank you. We have a question from Annie Verghese, who is a Sjogren's India member from Ahmedabad. She is asking about skin pigmentation that happens with most of the patients in Sjogren's syndrome. Is it due to the hydroxychloroquine that we are on, or is it due to the illness itself?
If you are on hydroxychloroquine, if one is on hydroxychloroquine, it is very likely the skin pigmentation is because of hydroxychloroquine, which is a reversible thing. So if you stop it, it goes away. Not that you want to stop hydroxychloroquine. Scleroderma can get hyperpigmentation of the skin sometimes in the long run. And in Sjogren's, if you had a purpuric rash, recurrent purpura, that leaves a hyperpigmented area on the skin. So I would say hydroxychloroquine number one, and then disease can be the number two.
And I think we just have to learn to live with the pigmentation, because we don't need to stop the medicine, or we can't stop the medicine. We have another question coming in from Mumbai. Vandana Chugh, another of our members, is asking, why do the symptoms of menopause aggravate? Do they aggravate because of Sjogren's? Is that common?
Well, during menopause, many patients do complain of an increase in pain. It's also something we see in rheumatoid arthritis patients, and in a condition called fibromyalgia, it occurs more commonly in the menopausal age group. So there is some evidence that estrogen can have a pain-killing effect. So when you have fluctuations in estrogen level, you do get an increase in pain definitely in these patients. But otherwise, the rest of the things are dryness can increase because of menopause in Sjogren's syndrome patients. But the other things are not really related to it.
A similar question from Jaya Brahma, who is in Muscat. She's again one of our members. She's asking whether Sjogren's syndrome affects menstrual periods, and does it bring in early menopause?
I'm not aware of any studies which show that it occurs early, except that if you have hypothyroidism along with Sjogren's, which can occur in about 10 to 15% of cases, then the thyroid problem can lead to menstrual irregularities, but not Sjogren's per se. Unless again you have low platelet count, then that can lead to increased bleeding, but otherwise not.
Sjogren's syndrome affects only 1% of male patients, is what you told us. But those male patients also have a lot of problems, similar and culturally a little different from those that women face. हमारे एक patient member है जो MP में रहते हैं, उनका नाम है सुनील पाठक जी. उनका question ये है कि क्या ये अनुवंशिक बीमारी है? मेरी फैमिली में किसी को हो सकता है क्या? I think you've already answered it, but just to...
Yeah, well, generally if you have, ये ऐसी बीमारी नहीं है कि जो ट्रांसमिट होती है. If you have one autoimmune disease, the chances of an autoimmune disease in your family members become higher than the normal population, but otherwise it doesn't necessarily go to your child. So I would say that the chances are slightly more than the normal population, but not necessarily so.
We have a question from Deepa Bhagat from Mumbai. She has a number of problems, but she wants to know particularly if there is any new treatment which has come for very severe dry eyes.
Well, there are some new compounds which have come. I'm sure that people have tried cyclosporin eye drops, and then there are some new compounds which are not available in India as of now. But there are compounds like diclofenazole and those kind of things which have come as eye drops. but nothing really remarkable. So I would say that there is not much role of immunosuppression in dryness. So you would have to go to the eye specialist for the new compounds that have come.
As far as I know, we have a lot of methods by which dryness is controlled. First, there are refresh eye drops or tear drops, and there are punctal plugs. There are also the new drug which is recesses, which cyclosporin. So all this put together also, in some cases, doesn't work. So I guess that is the problem that she's talking about. Another problem that we often face as patients is that we suffer from multiple problems, and therefore we have to go to multiple specialists, and each specialist prescribes a medication. What do we do about drug interaction or interference, and is there any way that we know if one drug is really interacting with another and causing other problems?
Well, I think that's basically the job of the prescriber when he writes that he or she has to see to it that these are drugs which don't interact with each other. By and large, the prescriptions that these patients carry don't have much of drug interactions. So except for drugs like cyclosporin, which if you used orally, some other drugs, or drugs like acetylcholine, which can have a problem with a drug called allopurinol, which is used for gout, again, which is more common in males than in women. Most of the drug interactions don't really occur. So I think that would be the job of a prescriber to see that he or she writes it down.
So would it be your advice that every patient should take the prescriptions of
Absolutely.
The other doctor to the doctor?
I think that's important to show, yes.
That would be an important message to go for the patients. Another question from Purvi Doshi, who is also the co-founder of Sjogren's India, is can a Sjogren's patient donate blood?
That's an interesting question.
Or organs, maybe you can expand that.
Generally, most of the transplant registries people that they would not recommend blood donation or organ donation. These patients have autoantibodies which are positive in their blood, and one is not sure if that could, although there is no real evidence to show that it occurs by just transporting blood, most registries would not allow blood or organ donation in these patients.
So I guess we need to be very careful.
Yeah, also the fact that these patients are on immunosuppressant, those kind of drugs, so most of the times no.
Okay. We have a question coming in from Neetu Wadhwa from Scleroderma, India. She lives in Delhi. Her question is, what is the scene of stem cell transfer? What is the scene of stem cell transplant in India for treatment of a few rheumatoid diseases? What kind of research is happening in this area?
Well, no real big research. I haven't seen a publication from India as of now. There are case reports, there are anecdotal reports. There is some work being done at CMC Vellore in animal models. There is some work in Pune, and there are few case reports also done in the military hospital Delhi, the R&R hospital Delhi, where people have done stem cell transplants, and also some transplants done in Ahmedabad, actually, the cancer hospital in Ahmedabad. But the disease that is most likely to benefit is scleroderma, because we have very few options in those patients with other diseases. So I would say, as of now, no real large-scale studies. We need to really do those studies, especially in scleroderma.
One of the questions which I receive as a patient educator all the time is, what can we do about brain fog? Can you first tell us what brain fog is and then explain how can we deal with this?
Well, the brain fog is believed to be because of the cytokines, as I said, the chemical changes which occur in the body from the serum.
So what exactly happens when we say brain fog?
Because of the flurry of cytokines in the brain, that you get these kind of confusion in these patients sometimes. Sometimes it's also because of what is called chronic organic brain syndrome, which means that the damage in these brain parts has been done because of long-term lack of blood supply. And so if it's an acute problem which is just occurred, then it's reversible. But if it's a chronic problem which is ongoing for quite some time, because these patients have a lot of cognitive defects, then you need to just brain exercise, which means you need to do puzzles and those kind of things to reactivate the brain. But if it's an acute problem, then you can treat them with the drugs that you use for the other kind of component insurance.
I suppose one of the most debilitating problems that Sjogren's patients face is that of fatigue. And fatigue is very less understood by other people because they can't measure or see how tired a person is, and that also leads to confusion in the brain and not being able to really work to one's capacity. So, are there any fatigue fighters?
Well, there are fatigue scales. Fatigue is another problem which cannot be measured very easily. So anything that cannot be measured is always a problem. But there are scales we have, and we now, if we look at the trials, clinical trials, then most multinational companies would need you to do the fatigue scales to prove that the drug is working. Again, in fatigue, it could be because of inflammation, which means you could have the cytokines which are high in your blood, high ESR and those kind of things, and then you treat them with immunosuppressants. And when you give them immunosuppressants like steroids, the fatigue improves. But a whole lot of Sjogren syndrome patients or even lupus patients, those have fatigue, which is again because of long-term disease and which is difficult to treat, I agree. And so in those, you try to ask them to cope with these things with exercise and vitamin D and those kind of things. You have to look for the reversible causes, but sometimes you can't find them, and you just try and reassure them and give them the best possible exercise schedules.
Another question which often comes up is, are rheumatic diseases patients more prone to mental illnesses?
Not really. I don't think there are case reports of patients of lupus presenting as schizophrenia and those kind of things. There are a lot of cognitive problems in these patients. So about 60 to 70% patients in the long run would have cognitive defects, which means they won't be able to do the subtle calculations that a normal person can do, but not really apparent overt disorders like depression or bipolar. I don't think there is really any evidence to suggest that these are increasing among these patients than the other patients.
However, as patients, we have often experienced that we get labeled as being depressed. Diagnosis takes a long time, and a lot of doctors also tend to put down patients' problems as being suffering from depression or things like that. This is something that a lot of our patients have reported.
Well, so there is a lot of secondary depression, agree, but it's not primary depression or major depression. Most of these patients could be depressed because not just because they have the disease, but because of the changes in their blood which lead to depression. So that is not uncommon.
Maybe we have time only for one more question now. So I will ask the question which has just come up, which is, please explain the need for calcium and other supplements in the treatment protocol.
Well, there's a lot of work on vitamin D in autoimmune diseases. So I would say that you need to keep your vitamin D levels to the tune of about 30 micrograms per deciliter, towards a higher side, and you could supplement yourself with vitamin D. It may not make sense to get vitamin D levels done in a country like India. Just give them vitamin D in the doses which are recommended. Calcium, again, there's a lot of confusion because there are a couple of studies from the US where they show that high calcium intake will lead to increased incidence of chronic problems. But in postmenopausal women, yes, calcium supplements are needed to the tune of 500 to 1,000 milligrams per day with 800 units of vitamin D. But in premenopausal women, if you're on steroids, then yes, you would need to supplement them with calcium, but not otherwise, and not in males. So
what is the best time to take calcium? Is it after meals, before meals?
Well, it depends on what kind of the compound you have. It's calcium citrate, then you can take it with meals also. But otherwise, if it's calcium carbonate or some other drugs, then it's best taken half an hour before meals.
And do we also need to take sodium alendronate and bisphosphonate and things like that, which...
Well, most of us wouldn't use bisphosphonates in premenopausal women because, but in postmenopausal women, especially if you are going to be above 10 milligrams of prednisone for more than 3 months or for a long time, then yes, we would give bisphosphonates to these patients.
Let us go to the last question: is why are mornings so difficult for us?
Well, all inflammatory illnesses are worse in the mornings, be it asthma, be it Sjogren's, be it rheumatoid arthritis. It's because it's one of the features of inflammation, be it backache and ankylosing spondylitis. It's always worse in the morning because the fluid rushes from the blood streams to the extra spaces of your body during the night and early morning. So that's a simple reason. And the corticosteroid levels in your body are lowest in the morning. So that's the time when you have the maximum problem. It is very well known as a part of inflammatory problem.
So the way to deal with it is to get up and get going.
That's true.
Okay, I think it's time for us to wind up now. Thank you very much, Dr. Pandya, for being with us and for patiently answering so many questions. Before we end, I'd like to just request everyone to please log in and use the feedback form on the link that is given to you to give us some feedback on how you have received this program. If there are any suggestions and ideas for new topics, हम आपकी तरफ से सुझाव लेना चाहेंगे ताकि अगले प्रोग्राम में हम इस तरह के फोकस्ड डिस्कशंस भी कर सके. आप व्हाट्सएप से भी हमें सुझाव भेज सकते हैं. एंड we would like you to leave behind your name and contacts. तो अगले प्रोग्राम के लिए हम आपको कांटेक्ट कर सके. इसके अलावा हम एंड करेंगे हमारे टेक होम मैसेजेस की स्लाइड जरा रखेंगे. बेसिकली सपन जी ने हमें आज बताया है कि ये जो रूमेटिक डिजीजेस है वो ट्रीटेबल है और उनको ट्रीट करना बहुत जरूरी है. गठिया रोग का इलाज हो सकता है, शायद मिट नहीं जाएगा पर उसका इलाज जरूर करना चाहिए. अपने रोग को समझना और उसके साथ अच्छी तरह जीने की कोशिश. We must understand and accept our illness, and this includes patients and family members. We need the family to accept the problems and the challenges that the patient is facing. Proper treatment and regular follow-up with a rheumatologist is very, very important. सही treatment और regular follow-up अपने रोग को नियंत्रण में रख सकता है. ट्रीटमेंट के साथ साथ जीवन शैली में भी अनुकूल बदलाव जरूरी है. We need to accept lifestyle changes. Maybe it is a change of the job profile. It is taking little breaks in between your day. Whatever needs to be done to take care of yourself, we need to do that. Keeping a positive attitude is very, very important. खुश रहने की कोशिश हमेशा की जानी चाहिए. अपना ख्याल रखें और खुश रहिए. One of the most important things is to create support systems. The family is the first structure of support. Society, friends, they are the second structure of support, and therefore we as patients need to become ambassadors of bringing better awareness about these diseases and explaining what happens to us to other people. Take good care of yourself and live well. Signing off now. Goodbye.
Yes.